is not here today, but we will still continue the good work. So go ahead and take roll.
Senator Boysko,
I've got 5.
Senator Pillion,
I'm here.
Senator Bagby,
I read them all, I know.
Senator Head,
Got a substitute.
Senator Pekarsky.
Here.
You have a quorum, Madam Chair.
Oh, excellent. Good morning, everyone. We are going to start with Senator Locke because she needs to get to probably like 5 or 6 committees. Senator Locke, which one would you like to start with?
I'd like to start with Senate Bill 739, which I would like to strike.
Okay. Do we need to take a motion for that, or no?
So moved.
Okay, and I'll,
We have to.
we do,
adopt that, yeah.
okay. Second with, by proxy, all those in favor of striking, say aye. Aye. Do you need to go one by one, or? Okay, all right. Thank you. Then we have,
Senate Bill 882.
okay. Whenever you're ready.
Okay, this bill comes as a recommendation of the Joint Commission on Health Care and will license certified anesthesiologist assistants in the Commonwealth. This is a healthcare workforce bill that will expand access to care and reduce the strain on the current anesthesia workforce. CAAs are highly educated and trained medical providers who work with anesthesiologists and nurse anesthetists within the anesthesia care team. They're currently practicing in 22 states, including our neighbors in North Carolina and D.C. They are recognized providers by Medicare, TRICARE, state Medicaid programs, and major commercial insurance companies. We already have many CAAs living in Virginia, but they cannot practice here. Instead, they are forced to work in D.C. or North Carolina. I received many emails from CAAs who live in other states but grew up in Virginia. They heard about the bill and are excited they may be able to move back home and work here. I've heard from Bluefield College in Blacksburg, which wants to start CAA training program there. People are excited at this opportunity, and we have several people here in support of this bill.
Thank you. Let's go ahead and take public comments in support, and then we'll go to questions if that's okay. Yeah, you can come right here or stand, whatever.
Great. Good morning, Madam Chair, members of the subcommittee. Sarah Graham Taylor on behalf of the Virginia Academy of Anesthesiologist Assistants. My first exposure to this issue was not here in the General Assembly. It was a simple post in a Facebook group for military spouses in Northern Virginia. And a military spouse shared that her husband was being stationed at Fort Belvoir and asked her advice about where they should live. She's a certified anesthesiologist assistant, but because Virginia doesn't license CAAs, she couldn't practice here. And she wanted to find a place where her husband could commute to Fort Belvoir and she could commute to DC for work. And that post stayed with me, and it is exactly what this bill is about. It's about highly skilled, turning on the microphone. I said some really good stuff. This bill is about highly skilled, highly trained medical professionals like that military spouse who want to be a part of our healthcare ecosystem in Virginia. And it's about professionals who play a critical role on healthcare teams in hospitals and surgical centers who want to practice in the state they have chosen to call home. This is not about replacing anyone. It's about expanding opportunities and access and choice. Licensing CAAs in Virginia ensures we remain competitive in attracting top medical talent. It helps address growing healthcare workforce shortages while maintaining the highest standards of patient safety. And for that military spouse in my Facebook group and many others like her, including the CAAs and students here to share their stories, it provides an opportunity to contribute to their communities and continue their healthcare careers in the Commonwealth. We urge you to support this legislation, and I'll pass the mic to the students and CAAs.
Great. Come on up. State your name, please. Comments.
My name is Nicole Moore. Good morning. Thank you for having us today. I am a certified anesthesiologist assistant and the current president of the American Academy of Anesthesiologist Assistants, but more importantly, I'm a Virginia resident, and I've lived in Virginia for the past 10 years. I moved here for graduate school to become a certified anesthesiologist assistant and fell in love with the community, ultimately leading me to stay. I met my now husband, who served in the Navy for 10 years here, and we are looking forward to starting our family here near his family and his work. I currently must commute across the river to Sibley Memorial in Washington, D.C., since Virginia doesn't recognize my license at this time. I'm here to testify in strong support of SB 882, legislation that would authorize the licensure and regulation of certified anesthesiologist assistants, also known as CAAs. Like many states, Virginia is experiencing a healthcare workforce shortage, and CAAs would add an additional provider to the workforce. I completed my anesthesia training with Case Western Reserve University School of Medicine at their DC location, graduating with a Master of Science in Anesthesia. After graduation, I, along with all other AAs, took a national certification exam and continue to submit continuing medical education and recertification exams as laid out by our certifying body. All AAs possess a pre-medical undergraduate background and complete a comprehensive didactic and clinical program at the graduate school master's degree level. The typical AA master's program is 24 to 28 months. We're trained extensively in the delivery and maintenance of quality anesthesia care, as well as advanced patient monitoring techniques. We understand the disease states, pharmacology, and all other factors that can influence an anesthetic and ensure we provide high-quality care to our patients. We're not a new profession. CAAs have been serving patients for over 50 years. CMS recognizes AAs as qualified non-physician anesthesia providers, just like our CRNA colleagues. AAs are as safe and effective as nurse anesthetists. In my current practice, I work alongside CRNAs, and we work together cohesively. We give each other breaks, relieve each other at the end of a shift. As a CAA of 8 years and a Virginia resident, I strongly encourage your support of CAA legislation so Virginia patients can benefit from the highly trained care that CAAs can provide. I would love to be able to continue to settle down here and raise my family in the state that I've longed to consider home. Thank you for your consideration.
Thank you. Yep.
So you're a Virginia resident,
Yes,
and you're president of the National Association,
yes,
but you have to work in DC.
but I have to work in DC, correct.
Thank you, Madam Chair.
Thank you. I want to welcome, just a minute, our Chair of and Health, Senator Hashmi, and thank you.
Okay.
I would ask, I see a long line, if we can be very brief in our support, because Senator Luck needs to get to her committee, and we have a long docket. Go ahead, Steph.
I've got 5, come on.
I know, it's this guy, he's doing it to us. See?
Good morning, everybody. My name is Daniela Flamenco, and I am in my final year of graduate school to become an anesthesiologist assistant. I grew up in Prince William County, and I went to college at George Mason University. My parents and my 7 siblings all still live in the state of Virginia, raising their own families. One of the reasons I chose to pursue my master's degree at Case Western is so that I could stay close to home. Now that I'm a mother myself with a little 18-month-old, it's even more important to me that we are near family and I can be available to help my parents out as they get older. I was so excited when I learned that there was a bill this year in Virginia. That's why the 3 of us drove down this morning from Northern Virginia. If this legislation passes, this will be life-changing for myself, my little family, and many of my classmates. And I hope you'll support this bill.
Thank you for coming. Good, step up.
Good morning, Madam Chair and members of the subcommittee. My name is Felipe Hoglar Vieira. I am a student at Case Western Reserve University in the Master of Science in Anesthesia program. I am a proud Virginia native. I grew up in Reston, Virginia. I went to VCU. Just recently moved back to Reston to go to the program because that's where my family is and where most of my support network is. I am hopeful by the time I graduate, I will also be able to work in Virginia. I know you've already heard a lot about the profession, so I'll just add that I'm not an isolated case. Many of my classmates are in the same boat. So please support this legislation and add Virginia to the 22 states where CAs can practice. Thank you.
Thanks for coming.
Good morning, Madam Chair and members of the subcommittee. My name is Shannon Moore, and I'm also a student in training to be an anesthesiologist assistant. I grew up in Afton, Virginia, and know firsthand the challenges of accessing health care in rural areas. It's a major part of why I want to become a healthcare provider. I would love to be able to come back to Virginia and provide the same care in the community that I grew up in. I want to add that our profession is another addition to the anesthesia team. I want to work with both anesthesiologists and nurse anesthetists. I don't want to replace anyone. I want to join the team and deliver high-quality care to Virginia patients. I hope you support this legislation.
Thank you.
Good morning, Madam Chair. Julie Dine on behalf of the Virginia Hospital and Healthcare Association. We would like to associate our remarks with all of the CEAs that have gone before us, but particularly our interest is on the workforce component. So as Senator Locke noted, we are at a competitive disadvantage currently with DC as well as North Carolina, and we would love to have all these folks come and work in our hospitals. Please hope you consider the bill.
Thank you.
Good morning, Amy Parent-Savage on behalf of Children's National Medical Center in DC. We use this model and CAs in our facility in DC, and would love to be able to replicate that in Virginia. So thank you, we support the bill.
Clark Barano with the Medical Society of Virginia. We echo the sentiments of Julie Diamond in the hospitals. This is about workforce, and we support the bill.
Lauren Schmidt on behalf of the Virginia Society of Anesthesiologists. We support the bill.
Thank you. Anyone in opposition of the bill, please go ahead, step up, state your name. Comments.
Good morning, Madam Chair, members of the committee. I'm Michelle Satterland on behalf of the Virginia Association of Nurse Anesthetists that represents the over 2,000 licensed CRNAs in Virginia. And I want to first make it very clear that we are not opposed to CAAs. We've been ridiculed. We've been told we have a lack of patient safety, these things, so we would never do that to another provider. What we are concerned about and why we want to ask to put the pause button on this legislation is the impact it will have on our existing students who are seeking to become CRNAs in Virginia. We have 3 CRNA schools, ODU, VCU, and VCU has a Northern Virginia location, a Richmond location, and a Southwest location where they're training CRNA students. These programs, and I forgot to add, there's Mary Baldwin as well. These programs could accept more students. The problem is there are not enough clinical slot training opportunities within this state. These schools are already sending students out of the state of Virginia. And what happens when they send them out of state for training? They stay in that state. So yes, we completely agree that we have a workforce shortage. We completely agree that, all providers should practice to the top of their license, but we don't want to bring in another provider until we see the impacts it will have on our existing providers. I know that DHP, and I think I've shared this study with many of you, it was from 2017, they looked at licensing CAAs, and they gave a number of reasons why they didn't think it was feasible. There were 5 reasons. Many of those reasons have disappeared, but the 2 important reasons, the impact on CRNAs and the fact that AAs have to practice under the direct supervision of an anesthesiologist, would not help the workforce in the rural areas. So I have a couple of educators from our schools here today. I'd like to turn it over to them and let them talk about the first-hand struggles they're having getting students placed. We could bring in more CRNAs, but we simply don't have the slots to allow them to finish their education in Virginia. Thank you.
Madam Chair.
Go ahead.
Just a question real quick.
Go ahead.
If we clarifying, we do not currently have a CAA training program in Virginia, is that correct?
Madam Chair, that is correct.
Okay, for the question, Madam Chair? So if there's not a training program in Virginia that would dilute the slots for training, and the only CAAs that we would be bringing in were ones that had gotten, and I realize that something would stand up and would probably be done, but that would take some time to set up. How on earth would opening the door for this dilute what's currently there? That's an illogical argument to me.
Madam Chair, that's a great question, Senator Head, and I had to wrap my head around that one as well. There are 3 things that we're looking at in ways of the dilution that you're talking about. First off, if CAAs are licensed in Virginia, those schools in North Carolina, CAA schools in North Carolina and DC will be able to send their students to Virginia to access training slots here. That's dilution number 1. Dilution number 2 is, and this one's a little more long-term. We've heard what they just said, that they'd like to build a college in Bluefield, in Blacksburg. We've heard from other universities, existing universities, that they too want to build schools. So we know that long-term that's on the burner, so that will be, well, that's 6 years or so. We see that as dilution. But also more importantly, in the short term, a CAA cannot train a CRNA. So right now, in CRNAs and anesthesiologists have the ability to train a CRNA student. An AA can't do that. So if an AA is practicing, that takes away a slot, an opportunity to train a CRNA, and that's where the real dilution comes.
Madam Chair. I mean, we're always looking to expand our healthcare workforce. So that argument, I would be with Senator Head's, I would go along with Senator Head's comments. Anytime we can expand a healthcare workforce is possible, I would think, so especially in a shortage.
Thank you, Senator. Would you like to
Madam
follow up on
Chair,
that?
can I respond to Senator Pillion? We don't disagree. We agree there is an anesthesia workforce shortage. We have CRNAs, existing programs, CRNAs who cannot access training slots. So we're going to exacerbate the problem before we've fix the underlying problem. If there's a workforce shortage, we have programs already for CRNAs. We have students who want to be in Virginia. I just talked to a VCU educator. She said they had 555 applicants for this last round at the VCU for all of the different cohorts. She narrowed it down to 135 interviews. They were only able to select 65 of those applicants because she knew she would not have the slots. She had 5 students she desperately wanted to include, and she had to reject them. We've got an existing provider workforce. Why don't we focus on this right now and then figure out a way to bring them in without impacting our existing providers? I'd like to have Derek Baldwin speak from Mary Baldwin.
Morning, Madam Chair, members. My name is Derek Owens. I'm president of the Virginia Association of Nurse Anesthesia and professor at Mary Baldwin's Doctor of Nurse Anesthesia program. As Michelle said, VANA is not opposed to House Bill 167 and the licensure of anesthesiologist assistants, and we're not opposed to anesthesiologist assistants. We're opposed to the spot that they would take to remove training for CRNAs in the state. Currently, as Michelle said, there are 3 schools in Virginia. The 3 schools, along with the physician residents, must compete for training slots in Virginia. The CAAs would take a training slot, and as we just talked about, if a CAA was licensed in Virginia and a CAA was practicing, they couldn't train a CRNA or a physician anesthesiologist for in the program. So they would essentially take a slot for training. At the same time, Mary Baldwin University, similar to what VCU was talking about, we had 173 applicants this year, of which 25 will be accepted. We have 25 slots for training. Greater training slots could increase the amount of students that we could take every year. I think nothing has changed since the Department of Health workforce study in 2017. We should find a clear way to accept anesthesiologist assistants into the program without affecting our current training model.
Thank you.
Thank you. Thank you.
Appreciate it. Go ahead, come up, please. If you have new information, share that with us. And
My name is Karen Gillikin.
good morning.
Good morning, Madam Chair and members of the committee. My comments today are based on my 28 years of educating registered nurses to become CRNAs. Like Dr. Owens, I place clinical students in clinical rotations. This year we had over 200 applicants. We interviewed 90 qualified candidates. We could only accept 28. We turned away 62 qualified candidates simply because we don't have clinical placement. You talked about impact. We had a cardiac and OB rotation at Washington Hospital Center a few years back, and we were dismissed in order to make room for the AAs to come in and train there. So it has impacted us already. I still believe that nothing has changed since 2017 when they recommended against licensing CAAs in the state of Virginia. We send our students as far away as North Carolina, Maryland, Ohio, and New Jersey. for clinical rotations lasting up to 9 months that they're away from their families in Virginia.
Thank you.
Thank you.
Senator Head, did you have a question?
I do, Madam Chair.
Go ahead.
I'm perplexed with this because this is sort of the presupposition that the only addition to the workforce would be students that are not currently CAAs, and that seems honestly that's perplexing. Again, as I had said earlier, my other question though for somebody is, is there any difference in the time frame of the clinical training that has to happen for a CRNA versus a CAA? Is there a different length of time, a different level? Can you get more CAAs through the program than you can CRNAs?
Yes.
Can somebody explain that?
Yep.
Okay. Yes, the CRNA programs are 36 months long. They're in clinical for 24 months straight. The CAAs have already told you their program is a total of 28 months long, and I don't know how long they're in clinical. Someone from their end would have to answer that. But we have many more specialty rotations that our students have to have minimum case requirements for.
Thank you. Is there someone who can answer that? Go ahead. Step up.
Nicole again from the Quad A,
The mic, please.
Yeah, sure. Thank you. So the CAA training programs, as we stated before, can range from 24 to 28 months. It depends on the specific school itself. The students are in clinical for the entirety of the 24 to 28 months. So during their first 12 months or so, they're splitting time between didactic training and clinical training. Their last 12 to 16 months, depending on the length of the program, they're fully immersed in clinical training. So they'll go through all their subspecialties, essentially neuro, cardiac, OB rotations to specialize in all those fields. But the maximum length of training programs right now that we have is 28 months.
Thank you.
Yep.
Thank you.
I think the other point is that if a CAA is sitting a seat in a room providing anesthesia for that patient, that's a seat that my students can't be in. That's another barrier to us educating the students that we currently have.
Thank you. Anyone else in opposition? Other comments from the committee? Questions?
Madam Chair,
Senator?
this was a unanimous vote of the Joint Commission of Health.
It was. And if I may, Madam Chair, the study that keeps being referenced was from 2017, and I think that we can all agree that healthcare has changed dramatically in 8 years. And as Senator Pillion indicated, this Senate Bill 882 is coming as a unanimous recommendation by the Joint Commission on Healthcare. They had several recommendations. Some were not taken. And I believe that the one that the CRNAs wanted was one of the recommendations that was not voted on. And so it makes little sense to me to not license anesthesiologist assistants in Virginia when they want to work here and they want to be here, and it helps with what we have all heard this morning, the workforce shortage here in Virginia. So I would ask that Senate Bill 882 be recommended for reporting.
Thank you, Senator Locke. Thank you for everyone who came to testify. This is a hard one. There was a lot of conversation around. I think some of the concerns are valid, and I think they're worrisome. I also think that this warrants going forward to the full committee so we can have a more robust conversation around it and see where we end up as a whole. So with that, I think we'll go ahead and take the vote.
Do you need a motion?
Oh, yes, I need one of those. I made my own motion.
Madam Chair,
Go ahead,
I
Senator.
recommend that we report this to the full committee.
Okay, it's been, we have a motion, it's been seconded. We can go ahead and take the vote.
Senator Boysko, Senator Pillion, Senator Bagby,
Aye, by proxy.
Senator Head, Senator Pekarsky.
Aye.
Ayes 4, noes 0.
Okay, thank you.
One more
Senator
bill,
Locke.
but I'm not sure if you got the amendments. You got the amendments? Okay. to Senate Bill 826.
Can someone move those quickly?
Move the amendments.
Is there a second? Moved and seconded. All those in favor of accepting the amendment, say aye. Everyone in favor?
Aye.
Aye. Okay, those have been accepted. Go ahead, Senator Locken,
Okay,
please tell us.
Senate
what
Bill
the-
826 addresses occupational licensing, and research consistently finds that gainful employment is a key factor associated with the lower rates of reoffending and recidivism among people with a criminal record. Yet occupational licensing can create arbitrary barriers for former offenders who are making sincere efforts to engage in productive behavior. So Senate Bill 826 provides greater clarity, fairness, and transparency regarding the consideration of criminal conviction records in occupational licensing decisions. And so this bill amends a section of the code to prevent occupational regulatory boards or the Department of Health Professions from using vague terms like good moral character or moral turpitude to refuse a license, certification, or registration. And it would require that a board notify the applicant in writing of specific offenses that contributed to denial, how the criminal history directly relates to the occupation, and how they provided individualized consideration when making their decision.
Thank you, Senator Locke. Let's go ahead and put 5 minutes of comment for those who are here to support. Thank you. Yes. Go ahead, come up, state your name, please, and provide your comments.
Thank you. Good morning. My name is Trida Innes. I'm with Prison Fellowship, the nation's largest Christian nonprofit serving currently and formerly incarcerated people and their families. And yes, the ability to find and keep a job is a key factor in contributing to success.
Oh, yes.
We heard you. You keep going.
Thank you. We support the bill as it will help break cycles of crime, addiction, and recidivism. Thank you so much.
Thank you. Is there anyone else?
Good morning, Erin Corman with the Realtors. I haven't seen the amendment, but we are in support of increasing transparency with criminal history and background checks and how they are run through DPOR, so we do support the bill.
Thank you. Anyone else? Okay, let's do 5 minutes for opposition, if there is any. All right, it's been moved and seconded to report to full committee. All those in favor, I think we'll go ahead and take the vote.
Senator Boysko? Senator Pillion?
Aye.
Senator Bagby?
Aye by proxy.
Senator Head? Senator Pekarsky?
Aye. Thank you, Senator Locke. Yep, Senator Durant is next. Good morning. Oh. Oh, no. So you should, I didn't know. Well, she had to run too. Everybody.
We'll be okay.
Yeah, we'll be fine. Go ahead.
Yes, ma'am. Okay. Okay, thank you, Madam Chair, members of the committee. This is Senate Bill 1438. So we have another workforce bill. This will direct the Health Regulatory Board regulated by the Department of Health to enact regulations to provide a licensure by endorsement pathway for qualified applicants as practitioners of a particular profession or professions regulated by such board. So, Madam Chair, members of the committee, this is the difference between this licensure by endorsement. It's important to note it does not affect the compacts that are already in place. But it does create a pathway for a lot of different professions that would be impacted by it. We're talking about substance abuse counselors, school psychologists, and I think in a little bit of capacity, pharmacy technicians, a whole slew of other under the Board of Medicine. So there are 21 professions regulated by DHP boards that do not have a licensure by endorsement pathway, and many of these are Board of Medicine allied health professions that would allow the licensure by endorsement may allow applicants to be licensed faster, and it certainly would be a positive impact on the workforce of Virginia to help address the shortages that we keep hearing about over and over again. So I can get into kind of the details if you would like about how it would work.
I think that would be helpful.
Okay,
Yeah.
and I do have phone friends
Great.
too also, but the applicants for, currently, the applicants for the 20 professions do not have, currently have a licensure by endorsement. They would, the applicants that, who have any professions who have an equivalent license, certification, registration from another U.S. jurisdiction may apply for licensure by endorsement, which would only require board staff to verify an applicant has a license in good standing in another jurisdiction, and other board requirements the board imposes. So it would be a streamlined process for the board staff they could rely on to review of certain documentation performed by that state to issue an existing license. And I do have a few others that can come in and speak to this too. So,
Okay. And
so it, I'm sorry, Madam Chair,
Yeah,
one
go
more
ahead.
is to, when it comes to like the compacts, not every practitioner type has a national compact. And those that do exist do not include all the jurisdictions in the United States. So there's some that fall outside that purview. The licensure by endorsement pathway ensures that practitioners licensed in other jurisdictions have a pathway in the Commonwealth, so it doesn't require that reciprocity. It's just, we recognize theirs and don't have to have that from their, that participating other state.
Okay.
So it's not the same as reciprocity. It's recognizing it by the board that they have completed what we would consider sufficient and outlining that, and then I wouldn't call it fast track, but streamlining the application process.
Okay, thank you. Let's go ahead and put 5 minutes on the clock and.
Do I get up?
No, just stay.
Okay.
It's okay, don't move. State your name, please, and.
Good morning, Erin
Good
Barrett
morning.
from the Department of Health Professions. We appreciate Senator Durant bringing this bill forward. Licensure by endorsement is a standard licensure procedure for anyone outside of the jurisdiction who would like to come into Virginia to work. About 60% of our practitioners already have licensure by endorsement. This bill does not affect them. It will affect the other 21 practitioners that Senator Durant mentioned. The boards are able to do this through an existing statutory authorization, but the regulatory process is quite intense. It will be many, many years of regulatory actions and 21 of them altogether. This bill speeds up that process while not taking away the board's ability to distinguish what the requirements would be for licensure by endorsement. Each board can impose unique requirements that are specific to the practitioner type and that maintains protection of the public. I'm happy to answer any questions that the subcommittee has.
Okay.
Are there any questions from the subcommittee?
Yeah, I understood. There is a House cognizant, so Senator, or Delegate Price's did, I think it's headed to the floor now.
Oh, it's already.
Yeah, it's came through unanimously, I believe, in the docket.
Actually, I believe it's up in HHS on Tuesday, but it's come out of subcommittee unanimously.
Thank you. I just heard Senator Pillion said he cares not at all, but
I
thank
heard-
you for
I
that
heard,
comment.
yes.
I did not say that.
I heard it. Thank you. Is there anyone else here in support? Is there anyone in opposition?
Made report.
All right. It's been moved and seconded to report to full committee. If we could take the vote.
Senator Boysko? Senator Pillion? Senator Bagby?
Aye by proxy.
Senator Head? Senator Pekarsky?
Aye.
Ayes 4, no 0.
Thank you very much.
Good luck. All right, who do we have? Senator Srinivasan, you're next. All right, tell us the number of your bill and go ahead. All right.
Good morning.
Good morning.
Members of the committee, SB 1352 seeks to amend language in the code related to the licensure of certified nurse midwives, CNMs, and the licensure of licensed certified midwives, LCMs, CNMs and LCMs, where the bill allows for LCM the same practice authority as CNMs. Both are advanced practice midwives with extensive and identical education, training, and certification. There you go.
Yeah,
No,
there you go.
Sorry. Both are advanced practice midwives with extensive and identical education, training, and certification, but LCMs face restrictions in their practice requiring supervision by a physician. CNMs, however, may consult with midwives or physicians for 1,000 hours before practicing independently. The only difference between the two is that certified nurse midwives attended registered nursing school prior to becoming a midwife. Aligning practice authority for LCMs will remove barriers, enabling them to work more flexibly and improve access to maternal health care, particularly throughout rural and underserved areas. This bill is a recommendation of the Select Committee on Advancing Rural Health and Small Town Health Care, which I was very humbled to be part of last year, and was also part of the Momnibus package to strengthen maternal health care across Virginia. Thank you for your consideration.
Thank you, Senator Srinivasan. We'll go ahead and put 5 minutes and take comments for those in support. Go ahead. State your name, please, and share your comments. You can take a seat or stand. Well, take a seat. Thank you.
Thank you. I'm Karen Kelly. I'm the president of the Virginia affiliate of the American College of Nurse Midwives, and I'm also a certified midwife. And when I became a certified midwife, it was because I believed in the promise of midwifery to fill gaps in maternity care, serve diverse communities, and ensure every family has access to compassionate, skilled midwifery care. The CM pathway provided me with the same master's level, rigorous, side-by-side education, clinical expertise, and sitting for the same identical midwifery board exam as my certified nurse midwife colleagues, preparing me to offer comprehensive, evidence-based care. In fact, my first years of practice when I lived in New York, I was licensed with identical title, scope, and privileging, including independent practice, as the CNMs I worked with, which included precepting students on a CNM track. However, since moving to Virginia with my credential, I've encountered barriers that make it clear why a legislative cleanup bill is urgently needed to ensure CMs can fulfill their intended role in Virginia. The current discrepancy between CNMs and CMs in terms of licensure and practice authority was never the intent of the original legislation in 2021 that created the CM pathway in Virginia. It's an oversight that has left CMs in a regulatory limbo, unable to practice independently despite our equivalent training. This not only limits opportunities for CMs like me, but also perpetuates healthcare inequities by preventing us from contributing fully to addressing maternity care shortages, especially in rural and underserved areas. This cleanup bill doesn't change the scope of practice for CMs. It simply aligns our licensure and practice authority with that of CNMs, ensuring parity between the two credentials. For me, this bill represents more than policy. It represents a chance to finally do the work fully that I was trained for, to provide the care my patients deserve, and to help Virginia realize its vision of accessible, equitable maternity care. Without this bill, Virginia risks losing the talent and dedication of CMs who are ready and eager to serve. Passing this legislation is a simple and necessary step to empower midwives and expand access to high-quality care for all Virginians. Thank you for your consideration.
Thank you. Anyone else? And remember, the 5 minutes is total, so be cognizant.
No problem. Thank you, Madam Chair, members of the committee. My name is Katie Page. I'm a certified nurse midwife, and I've been in practice for 15 years, 13 of which have been in the Commonwealth. I work in hospital settings and have been, just wanted to speak on the challenges that the discrepancy in licensure create when we are trying to employ CMs in hospital settings or even train them in hospital settings. So this cleanup bill will allow us to more clearly adopt hospital bylaws that allow CMs and CNMs to have the same language, and so it makes that process much more simple for hiring and for educating. Thank you.
Thank you.
Good morning. My name is Miranda Schindler. I'm the secretary of the Virginia Midwives Alliance and a licensed midwife here in the state of Virginia. We just wanted to speak in support of this bill to increase the midwifery workforce and make an impact in maternity deserts in Virginia. Thank you.
Thank you. Anyone else in support? Okay. We'll take comments in opposition.
Seeing none, I would recommend reporting. Second.
All right, it's been recommended to report and seconded. Go ahead and.
Senator Boysko? Senator Pillion?
Aye.
Senator Bagby?
Aye, by proxy.
Senator Head?
Aye.
Senator Pekarsky?
Aye.
Ayes 4, no 0.
All right, that motion passes.
Thank you, Madam Chair and members.
Thank you. I don't see Senator Obenchain, so we'll go to Senator McPike. What do you have for us this morning?
Madam Chair, I have all smiles on it. Happy
Love
Friday
it.
for you.
Happy Friday.
Senate Bill 1318, Madam Chair, members of the committee. So this past year, fire and EMS have had a fairly significant transition as new federal DEA rules require all drug boxes and meds to have a license under DEA. And so that now there's a considerable amount of work that's being done across the Commonwealth to include all sort of onboard fire and EMS medications under the EA provisions. So this would add both a new reg process for the pharmacy board, as well as adding membership to the board, recognizing that now the fire and EMS services would be one of the largest pharmacies across the Commonwealth. So adding their board and voice to that process is an important component to fire and EMS members. I do have one quick. Thank you. I now have a green button.
Sorry.
We do have one quick line amendment.
Is there a second? Moved and seconded, all those in
It's-
favor?
And I'll
Aye.
do a quick readout of
Ahead,
it.
Senator.
Thank you, Madam Chair. Would be in line 19 after station, striking it, it'd be to insert or properly registered EMS station, just recognizing not all locations have fire stations. Some are fire, some are combination thereof.
Okay.
And then a second one for line 25 after member, insert both who shall be active advanced EMT provider or EMS physician, just to recognize those two components.
Thank you, Senator. If that is all, we will go ahead and take any comments in support. We'll put 5 minutes. We may not need it. Okay, all those in opposition?
Madam Chair, I would
Go
just
ahead,
add, this is a
questions.
problem that my EMS in Southwest Virginia have complained about. I appreciate the patron bringing this forward, so I would recommend report.
It's been recommended to report. Do we have a second? Do we have a question?
I have a question,
We'll
too.
pause for a minute. Let's-
You have,
I was hoping that there'd be somebody from the administration or board of pharmacy or somebody that would be able to sort of weigh in on this as well, just to make sure, because I don't mean any harm to the bill. I just want to make sure I'm hearing everything. And
Is there anyone? Go ahead, step forward.
Good morning.
Good morning.
Committee Chairman, members of the subcommittee, and Caroline Jern, Executive Director with the Virginia Board of Pharmacy. May I answer any
Yes.
questions that you have?
Senator Head, go ahead.
just, you all like this, you're okay with this bill? I mean, I haven't heard anything from you one way or the other, so.
Sure. So for the last year, Committee Chairman, for the last year, the Virginia Board of Pharmacy has worked very closely with the EMS and firefighter associations and stakeholders. We've actually already promulgated these emergency regulations.
Right.
They're currently in effect, and we are in the replacement of those emergency regulations because emergency regulations are temporary. They have to be replaced with permanent regulations. So we're actually at the point of proposed regulations in the standard administrative regulatory process to replace the emergency regulations. To my knowledge, all stakeholders were happy with what the board came up with. We had multiple rounds of public comments, very, very active engagement from stakeholders. I'm not aware of an issue of concern on it.
Thank you. Sounds good to me. Any other questions? All right, we
That
were.
would be a second.
All right, it's been moved and seconded. Let's take the vote. Oh. Okay, go ahead. Or though we are okay, we'll pause, I guess. Okay. Okay, let's go ahead and take the vote. I think we're all in a good place, so.
Senator Boysko? Senator Pillion? Senator Bagby?
Aye by proxy.
Senator Head? Senator Pekarsky?
Aye.
Ayes 4, no 0.
That motion passes. Thank you, Senator McPike.
Madam Chair.
And I think now we just have,
Is Owen Shane?
I don't see him here, so we should,
He's next, right?
yeah, he's next, but
Maybe Andrew went to get him.
you're calling him? Okay. Do you want to try to get one in before?
Oh, it'd be my pleasure.
Let's do it. Come on.
Do you want me to?
Up to you, whatever makes you feel comfortable.
Sure.
Pick
Okay.
one.
Um,
Easy one.
Yeah, I'll do an easy one. So, Madam Chair, members of the committee, Senator
Oh.
Owen Shane is here. And you'll
Senator, come on down.
Fifth bill by 9:15 this
Oh,
morning.
that must be a
How about
record.
that?
Go ahead. Share, this is SB 1152.
Yeah, Madam Chair, I've got a substitute.
Okay? Is there a motion?
I'll move substitute. Second.
Okay, it's been moved and seconded. All those in favor of the substitute, say aye. Aye.
So, Madam Chair, this deals with the exciting topic of nursing home insurance. There have been a lot of nursing homes that have changed hands over the past 10 years. There is a trend towards hedge funds, venture capital funds, purchasing large portfolios of nursing homes, and they change hands. And when they do, they typically change insurance. Many of the owners are not in Virginia. Our insurance requirements are, shall we say, confusing. And increasingly, there have been residents or whose residents' families who have had bad things happen to them in nursing homes who go through litigation only to find that there is limited to no insurance still available, which is mind-boggling. And there are a couple of reasons for that. One is some of these owners have policies that are eroding policies, which means that they have a policy that is compliant, has the $1 million general liability. Let's just set aside the medical malpractice for now, but general liability policy. And the policy language says it can be eroded by legal fees. So at the end of the case, there could be a catastrophic injury or death, and all of a sudden they start talking about resolving it and find that instead of $1 million, there's $300,000 left on that policy, which is clearly not the intention. The $1 million of insurance is supposed to be there to protect the nursing home owners, but also the residents of the nursing homes as well. Then the second problem is that for some of these large nursing homes, the worst case scenario is somebody who owns 50 nursing homes has a $1 million policy with single limits for 50 nursing homes. And if something bad happens, it disappears. But what this does is says that the coverage has to be available for each occurrence. The law basically says they have to have that $1 million per facility, but we found that many do not have it per facility. But this says per occurrence. And I know Mr. Johnson represents the association. I did make some changes that he had asked for, not all, in order to accommodate the owners. They wanted to require a cap of $3 million. So rather than unlimited, so 20 people get hurt badly or die, having a $20 million cap might be excessive. This, instead of just saying $1 million total policy, would say they're required to have $5 million instead of the $10 million that, $5 million instead of the $3 million that the association requested. But it does basically those two things.
Thank you. Let's go ahead and put the 5 minutes on and take comments in support of this.
I'm Lone Ranger probably in support of it today, but I will tell you that there is a group of advocates for nursing home residents and attorneys who represent their families who are affiliated with Virginia Trial Lawyers Association who have been working on this issue for 4 years, because this comes up with surprising frequency.
Thank you. Well, you're not alone.
I think you called for support.
I did. Oh, okay.
I'm it. And
all right. Seeing
I'm not
no
gonna-
support, let's go ahead and take opposition.
Madam Chair, Scott Johnson, General Counsel for the Virginia Healthcare Association. Our members are roughly 98% of all the nursing homes in the state. I want to thank Senator Obenchain. Thank you. There we go. I want to thank Senator Obenchain. He had put this bill in last year. We carried it over. We've had discussions. He told me he was going to put this bill back in this year. We did offer him some language because the introduced bill we very much are opposed to, and he has incorporated some of this. I'm just seeing the substitute now. But this is a confusing section. Believe it or not, we had it on the books 13 years. And I think some of the confusion he has encountered has also been encountered by some of the owners, because it wasn't clear in the line 121 and 122 of the substitute. It wasn't clear to a lot of people that these limits really should be per facility, and it wasn't clear that we're talking about general liability insurance coverage versus professional. And so some of the changes that he has made at our request bring clarity, and we're grateful for that. One thing I would also bring to your attention that I just learned and I have not talked with the senator about is on line 124, this mandate to have insurance, at the end of that sentence it says, talks about coverage for negligence or criminal acts. And again, that's been the law for 13 years. But I don't know of anybody that can purchase insurance to coverage criminal acts. So my request respectfully would be on the line 124 at the end, delete or criminal acts, because that just doesn't exist. And if we don't clean that up, down at the bottom on line 130 or so, if you don't maintain the coverage, our friends at VDH can take your license, and we don't want that to happen. So that would be one thing that I would leave with you. I would also promise I'll take this language back to the insurance agents that work with our various members. We just want to make sure that we are not precluding available coverage or give options. Some people have eroding policies, which means if you have $1 million of coverage under the senator's substitute, at least 50 grand could be taken for defense. Other people use insurance policies that have deductibles. Right. Meaning the nursing home pays out the first 50, 100,000, whatever it is. So there are different varieties. And remember, all of this is going to be involved in the reimbursement from Medicaid to nursing homes, which new soundbite reimbursement to nursing homes is not 100% of cost. So this is going to have a financial factor that I would think that Senate Finance needs to evaluate as well. But with that, I'm glad to answer any questions. But again, on line 124, I would ask the senator's permission to remove all criminal acts and answer any questions you have.
Go ahead, Senator.
I'm in all due respect to my friend Mr. Johnson here, I'm a little dismayed at the not knowing that insurance against criminal acts, or maybe I'm confused about that. But I know in my business and home care for seniors that I'm required by the Commonwealth to carry $1 million coverage for criminal acts, for crimes of dishonesty, and it's not hard to get. I'm just wondering if that is, if Senator Obenshain can give some clarity on this, because I think it's pretty important to leave it there.
I'll come to Scott's defense on this. That's a different kind of coverage. That's covering you for criminal acts of your employees that may hurt you and your business. But
actually, Madam Chair, to clarify back, that's actually to cover it is to cover, yes, if one of our employees does something that is a criminal act, it covers and makes whole the family, which I think is the intent of what you're trying to do here. If it's not, I'd like to know where we're going on with this.
Senators, wait a minute. Speak through the chair, and let's each give each other their own time. Senator Obenshain.
And I know Senator Head's trying to help me, and I appreciate that. And actually, what Scott has raised is something I hadn't thought about either, and we do actually have a bill that's on the floor today dealing with liability for criminal acts. I think maybe he and I need to talk about that and cogitate over that rather than do that on the fly, since that is existing language, and I'm certainly open to working with him on that. But I would hope we wouldn't on the fly tinker with language in the existing part of the code. I'm not trying to affect that, but I'm certainly open to it.
Mr. Johnson, do you want to add anything to that? Or
Senator always has an open door for me, and I'm grateful.
okay.
So, Madam Chair, Mr. Johnson, with those changes, does that in turn garner your support of this bill, or are you still opposed to this bill?
I
Mr.
would-
Johnson?
Madam Chairman, Senator Pillion, I would like to take this back, since we're just seeing this on words on paper, back to the insurance experts we talk to. We work a lot, or a lot of our members work with Marsh McClellan, and they're the experts at that, and I promise to get an answer back to Senator Obenshain and to the committee. But right now, I would say he's made strides in a good direction, but I can't say that we're at support. And hopefully, at minimum, we would not oppose it.
Okay, thank you.
Thank you.
Is there anyone else in opposition?
Yes, Dana Parsons, representing Leading Age Virginia. We represent not-for-profit nursing homes, standalone, as well as parts of continuing care retirement communities. We've spoken with our insurance agents. We have some concerns about the introduced bill and the impact on our membership. We're seeing the substitute for the first time, so we too would like an opportunity to review it and work with the senator.
So, Madam
What do we
Chair.
want to do? Senator Head?
I think this is important, because I think it does need to bring clarity, and I think it's a really important issue. Obviously, there's still some wrinkles on there, and I learned something about the insurance coverage. It makes me want to go drill down on what my own coverage looks like. But it's never a bad thing. But I would like to move to report with everybody knowing that the understanding is that there's got to be some work done before we get there, because that support may have to erode by the time we get to full committee, so.
I'll second the motion.
Okay, it's been moved and seconded to report with the understanding that we are doing this for a larger conversation while you continue to work, Senator Obenshain, with everyone, and we'll give the full committee an opportunity to deal with it. Let's go ahead and take the vote.
Senator Boysko? Senator Pillion? Senator Bagby?
Aye by proxy.
Senator Head? Senator Pekarsky?
Aye.
Ayes 4, no 0.
Thank you. Yeah, all right, Senator Pillion.
Why are these people still here?
I don't know, they really want to hear all the great things you're going to do right now. Don't say that about your bills.
Okay, all right. Madam Chair,
Go
Madam
ahead.
Chair.
Where are we starting?
We're starting with
Senator?
Senate Bill 1360.
1360, go for it.
So, Madam Chair, this bill removes this is a bill that I carried in 2022, and it removes the July 1st, 2025 expiration date on legislation that was passed and was unanimously approved by the General Assembly and signed by the governor. The law lets the Virginia Board of Dentistry issue faculty licenses to foreign-trained dentists, foreign-trained dental graduates who are currently who are certified by the Virginia Dental School to meet its clinical and experience standards. The license restricts the graduate to teaching at an affiliated dental school, which we have one in the Commonwealth, and does not permit practicing elsewhere. This has worked well for the dental school. They've utilized this in addressing their faculty shortage, and the sky did not fall from 2022. Dentistry still remained solid in the Commonwealth, and I would like to pass this bill.
Okay, all those in support? Good morning. If you can turn it on then.
Kara Gunther with VCU. We are very grateful to the senator for, he brought the original bill and is helping us with this bill to remove the sunset clause. As he said, we've been highly successful in recruiting very talented faculty. We've recruited 6, mostly all postgraduate and PhD trained dentists to VCU School of Dentistry. We have proudly stolen them from some excellent institutions, including UNC, University of Michigan, University of Toronto. So we are, we urge you to support the bill, and we thank Senator Pillion once again. Thank you.
Madam Chair, good morning.
Good morning.
Trip Perrin representing the Virginia Dental Association, and we support the bill.
Thank you. Great. Anyone in opposition? Ooh, everybody wants more dentists. It's been moved.
And I'll second.
And it's been seconded, and we'll go ahead and take the vote.
Senator Boysko? Senator Pillion?
Aye.
Senator Bagby?
Aye by proxy.
Senator Head? Senator Pekarsky?
Aye. All right.
Ayes 4, no 0.
Motion passes. What's next?
Continuing on the Pillion docket,
Alrighty.
Senate Bill 1363 Madam Chair, eliminates the Board of Health Professions, the agency's only non-licensing policy board. The board struggles to obtain a quorum to meet, and the job it has been tasked to do can be achieved better by the individual boards of the agency or the department itself. The task and duties assigned to the board would be reassigned to those licensing boards or to the department, like I said, and the money that licensing boards paid for support services for the board would be retained and used to fund any duties inherited by the licensing boards, likely to be very minimal.
Anyone here in support?
Good morning, Madam Chair, members of the subcommittee. We appreciate Senator Pillion bringing this bill. Aaron Barrett on behalf of DHP. This board served a purpose in 1977 when it was created, and the umbrella agency was created, bringing together disparate health licensing boards. At this time, it has outlived its usefulness, as Senator Pillion mentioned. We struggle to obtain a quorum. The members of this board serve on other licensing regulatory boards that have heavy dockets and heavy meeting rotations, and those volunteers struggle to take another day away from practice to attend a board meeting where they only hear verbal reports of the other boards or verbal reports of divisions within the Department of Health Professions. Importantly, the employees that support the Board of Health Professions have full-time jobs supporting other boards within the agency, so we are not losing any state employees if this board is eliminated. I'm happy to answer any questions that the subcommittee has about this.
I do have a question. So you said they just hear reports, so what else are they tasked with doing or supposed to be doing or used to do?
Some of what they have been tasked in the past with doing are things like studying practitioner groups to see if licensure should be implemented by the General Assembly. Over the past 5 years, this body has sent those considerations generally to the licensing boards themselves rather than the Board of Health Professions. They are supposed to be tasked with reviewing things like the budgets of the licensing boards. They don't meet frequently enough to do that, and they have no authority to act on that. The boards themselves have to do that. Those are a couple of the duties that were tasked to the Board of Health Professions that are really no longer done by them.
Okay, thank you. Anyone else in support? Opposition?
Second.
Okay, it's been moved and seconded. Let's take the vote.
Senator Boysko? Senator Pillion?
Aye.
Senator Bagby?
Aye by proxy.
Senator Head? Senator Pekarsky?
Aye.
Ayes 4, no 0.
Okay, Senator Pillion.
All right.
Let's do this.
Senate Bill 1366, and Madam Chair, there should be a substitute available.
Let's move the substitute.
Okay.
Can we move-
Second.
Okay. All those in favor, say aye. Aye.
So
Substitute's
the
moved.
substitute just simply strikes a couple words that the Board of Pharmacy asked us to do. The bill removes the prohibition for hospitals to compound needed medications and distribute them with other hospitals within the same health system. This will support hospitals to improve timely access to needed medications and flexibility during emergencies and drug shortages in the Commonwealth. Virginia's restrictive statute prevents hospitals from centralizing compounding, limiting their ability to respond to urgent medication needs, manage drug shortages, and address crisis effectively. Increasingly common drug shortages, as we've all heard about, compromise patient care by delaying treatment, forcing substitutions that may be less effective or safe. And I think there may be a few people here to speak in favor of this bill.
All right, let's put 5 minutes and let's take support.
Good morning.
Good morning.
My name is Natalie Nguyen. I'm here for the Virginia Society of Health System Pharmacists, and I'm a pharmacist myself. Thank you, Senator Pillion, for supporting this bill. So just to clarify again, this bill removes that prohibition for hospitals to compound for all the other hospitals in the same health system. The specific prohibition only exists in the Commonwealth of Virginia and not other states. One of our members works for our Southwest Virginia health system, expressed that this bill will enable them to support more rural facilities, especially where there are no 24-hour hospital pharmacy services. There remains a reliance on sourcing medications from other suppliers. However, again, during drug shortages, as the Senator has mentioned, affects smaller facilities much harder than the larger facilities. Having that flexibility will certainly allow for reliable access. Another example is the critical need was during the Hurricane Helene disaster, where IV fluids were in shortage. Hospitals that ordered a drug called oxytocin, it's for fatal uncontrolled postpartum bleeding, was unable to receive this drug from other external suppliers because it was also in shortage. So essentially, if we were able to compound in-house and share with the other hospitals within our health system, we will have a greater role in preventing those maternal deaths. So please do not let the failure of this bill be the reason why we are unable to care for our patients. Thank you so much.
Thank you. Step forward.
Good morning, Madam Chair and Senators. My name is Anjali Thalwar, and I'm also a pharmacist at VCU Health System. VCU Health was able to greatly benefit through the governor's waiver exemption during the fluid shortage crisis of fall of last year, as well as the hospital-specific exemption during the recent January water crisis. With this, we were able to quickly pivot and provide continuous critical care to all of our patients when buildings were closed due to lack of heat, due to lack of steam, and we were able to provide centralized compounding operations with centralized resources to provide sanitary conditions. Supporting Senate Bill 1366 to help institutions like VCU Health continue to operate as a level 1 trauma center and not during times of crises would be integral. Thank you.
Thank you.
Morning, Madam Chair, members of the committee, Brent Rawlings, Virginia Hospital and Healthcare Association. We strongly support the legislation. You'll recall during this recent emergency, Baxter Helene, the governor issued an executive order, state of emergency due to the hurricane. And part of that was a waiver to allow exactly what this bill does. But the minute that state of emergency ends, so does this ability. And so we see it critical as part of our supply chain resiliency efforts to have this in code to allow this to occur ongoing without the need for executive orders. So we support the measure. Thank you.
Thank you. Anyone in support? Nope. In opposition?
Second.
Okay. Let me ask a quick question.
Okay.
Sorry.
I don't know if I can answer it, but I'm glad to entertain your question.
So why was this on the books to begin with? Someone mentioned we're the only ones who do this in the country. We don't allow hospitals to compound.
We can compound, but we can't share with the same hospital system.
Yeah.
So I'm sure that somebody didn't want drugs transported from place to place. Virginia was being over restrictive. That's why we're.
Okay.
Seems like a good idea.
I'm just wondering
why we were so
restrictive, if you have any.
Caroline Tarrant, Executive Director, Virginia Board of Pharmacy. No, I have no idea why it.
Okay, all right. Okay,
that language has been there a long, long time.
The important thing is we are the only ones.
No more, hopefully.
No more.
Well,
but currently.
I'll give you more context.
Can you elaborate on that? Yes, please.
So the FDA also regulates hospital compounding as well, compounding in general.
Sure.
There's draft guidance document that the FDA put forth in, I believe, 2017, 2018. They put forth a revised draft. They still have not put final language in place. So this issue is regulated both at the state and the federal level. It does generally have to be patient-specific compounding. There are some provisions for hospital pharmacies that are growing in popularity to be able to compound more in bulk to take care of patient care efficiencies, things of that nature. We've worked closely with them. Historically, it has been patient-specific, and my guess would be that is where this language came from years ago.
Okay, thank you. Okay, well, people seem to like it, so. We had a motion, and it was seconded. Let's go ahead and take the vote.
Senator Boysko, Senator Pillion.
Aye.
Senator Bagby.
Aye by proxy.
Senator Head. Aye. Senator Pekarsky.
Aye.
Ayes 4, no 0.
All right, Senator
Madam
Pillion.
Chair, Senate Bill 1367 is being introduced to ensure better access to care for patients within our state and local correctional systems. The bill has been vetted by the Virginia Board of Pharmacy, the Virginia Department of Corrections, and the Virginia Association of Regional Jails, and I'm not aware of any opposition. The bill allows correctional facilities to maintain a floor stock of long-acting or extended-release prescription drugs for the treatment of mental illness or substance use disorder, and ensures that the medical professions who administer such prescriptions have access to them when a patient is due for treatment. The bill makes no change in the standard of care, nor does it impact which medical professionals handle or administer the medications.
Thank you. Anyone here in support? Let's do our 5 minutes.
Madam Chair, members of the subcommittee, David May on behalf of Brayburn Pharmaceuticals. I'm not going to stop the train here. I'll just say appreciate the patron for bringing the legislation forward. We support it. Just makes 2 small changes, not earth-shattering legislation, but it would save the.
You felt it shattered the earth.
Well, statutorily.
Don't say that.
In effect, this could really. In effect, though, it could save the state a lot of money for wasted medications, and it ensures that patients can have the medication they need when they need it.
Yeah. Thank you. Anyone else? Okay. He thought, I thought it was earth-shattering. It's fine, Pillion. All right. Anyone in opposition, step forward. Forever hold your peace. All right, do we have a motion? Or questions?
I don't even know we need it now.
Okay. It's been moved.
Second.
Okay, now it's been seconded. Let's take the vote.
Senator Boysko, Senator Pillion,
Aye.
Senator Bagby,
Aye by proxy.
Senator Head,
Aye.
Senator Pekarsky.
Aye.
Ayes 4, no 0.
That motion passes.
Okay, last bill, but hopefully it's more impactful than the last one. Senate Bill 1475, and there is a substitute that we've been working on for a while now. So we finally got it. Okay.
Okay,
All
can
right.
we move that?
I'll make that motion to move the substitute.
Okay, moved and
Okay.
seconded. All those in favor?
Aye.
Aye. Okay, substitute accepted.
So, Madam Chair, basically this turns the original bill into a Section 1 bill. After some conversations we've had with stakeholders, I think everyone's can hopefully coalesce around this bill. This bill simply directs the Board of Dentistry to convene a work group to review licensure by credentialing statutes governing dentists and dental hygienists. They will then come back with recommendations on how these statutes can be updated, reflect a more expedited pathway for licensure with consideration given to the recent regulatory changes with the licensure by endorsement pathway to the Board of Medicine. The original bill was trying to align the Board of Dentistry with the Board of Medicine, but we've decided dentistry probably needs to study it a little bit more and include some pathways for dental hygienists as well. And that's the bill.
Great. Do we have anyone in support?
Madam Chair, the Virginia Dental Association supports the bill.
Great. Anyone in opposition?
Second.
All right. It's been moved. It's been seconded. I like this work study better. Thank you. Let's take the vote.
Senator Boysko, Senator Pillion,
Aye.
Senator Bagby,
No, I do. Aye by proxy. Don't leave.
Senator Head, Senator Pekarsky.
Aye.
Ayes 4, no 0.
Okay, that motion moves forward. Okay, this actually is not my bill. It's Senator Boysko's. She asked me to present this, and I will be candid.
You want me to do it so you don't have to?
Oh.
Give me the talk point.
Oh, sure. Go
So
ahead.
you can
All right.
remain the chair.
Yeah, why not?
Okay.
Oh, okay. That.
Open here. Okay. I don't know if I want to do this one.
Okay, so I can't present and preside? Is that, I guess, I mean, we're all friends here. Come on. All right. Is that okay? Okay. All right. Let me do the best I can with this because I just actually got this. So this is SB 1135, and it is about synthetic psilocybin. Did I say that right? Mm-hmm. Okay. And apparently there's also an amendment in the nature of a substitute here. Can we move that?
So, yeah, make the motion.
Is there a second? Second. All right, all those in favor say aye. Aye. Anyone else? Aye. All those in favor?
Aye.
Okay. It's been accepted? Okay, go ahead. And Senator Boysko says that after consideration, the advocates who requested the bill would like to amend the language regarding the time frame and removing the brand name of the synthetic psilocybin powder, so it covers all forms of the improved synthetic psilocybin powder. So SB 1135 would allow for the regulation of synthetic psilocybin in Virginia only after it's been approved by the Food and Drug Administration and rescheduled by the Drug Enforcement Agency. And synthetic psilocybin has been proven to show, oh, did I do something wrong? Oh, I do? Oh, after I said all that? Oh, I thought we were okay. All right, Senator Pillion, can you be the chair guy?
I can.
Okay. Oh, I have to write it out too? Holy moly. Okay. Stella, Health, and who are you, Pillion? So confused.
Here we are.
Okay.
Continue,
All right.
Madam
Yeah.
Chair.
Yes, sir. Okay, so synthetic psilocybin has great benefits for those who are suffering with PTSD, anxiety, and other mental health issues, especially drug-resistant depression. So I think the point of this bill is just basically to give us just yet another tool in the toolbox for those who are suffering from persistent and especially drug-resistant depression. As you all know, it is a debilitating disease, and as we are finding more ways to deal with it, patients should have the options to try whatever has been deemed safe by the FDA. And I will try to answer questions if, well, Mr. Chair.
Okay. Do we, any questions from committee? Okay. Hearing none, we'll hear from members of the audience that are in support of this piece of legislation. Go ahead.
Mr. Chairman.
Sure. Go ahead.
Thank you for the opportunity to speak. I'm Nicole Lauder here on behalf of Compass Pathways. With me is Tess Bettler from the company. She can speak to the bill, but before we get there, I did have the opportunity to speak with the Board of Pharmacy this morning. One more small line amendment, if we could, please. On line 25, instead of after 30 days, we would strike that and say instead at its next quarterly meeting. This just gives the board a little latitude and not be under the gun, and not have to schedule a new meeting.
Right.
Just for the purpose of taking this action.
So you're fine with that amendment?
Yeah.
Okay.
Yeah.
So
Move the amendment.
Second. All in favor?
Aye.
Say aye.
Aye.
Thank you.
Amendment's adopted. Okay. All right. Go ahead.
Mr. Chair, members of the subcommittee, thank you for taking the time to consider SB 1135. My name is Tess Bettler, and I'm the Senior Manager of Advocacy and State Government Policy at Compass Pathways, and here in support of the bill today. I'll skip what the bill does because I think we've already explained that. But as you know, psilocybin is currently a Schedule I drug in Virginia. However, certain formulations of synthesized psilocybin are currently being studied by pharmaceutical companies for the treatment of serious and difficult to treat mental health conditions, including treatment-resistant depression, which occurs when a patient suffering with major depressive disorder is failed by 2 or more medications of adequate dose and duration. This affects approximately 1/3 of patients that are being treated for major depressive disorder. So in the event that a prescription drug containing crystalline polymorph psilocybin is approved by the FDA, the DEA will be expected to make a rescheduling decision soon after the FDA's approval, allowing for prescription medical use of the FDA-approved product in the USA. As Virginia does not automatically follow the DEA's rescheduling decision, if crystalline polymorph psilocybin is approved by the FDA, we would advocate for it to be rescheduled to align with the DEA's rescheduling decision in a timely manner. Doing so will allow patients in the Commonwealth with difficult-to-treat mental health conditions to have access to new treatments approved by the FDA as quickly as possible after approval. And if the FDA does not approve it, then nothing changes in Virginia. So in short, this bill helps accelerate patient access to innovative mental health treatments that have been FDA approved. So thank you for your time.
Okay. Any questions from the committee? No. Okay. Okay. Thank you.
Okay.
You have a question? Okay. All right. You're good. Thank you.
Thank you.
Sure. Any other members of the audience here in support of the bill? Okay, seeing none. Opposition?
Good morning. My name is Natalie Nguyen from the Virginia Society of Health System Pharmacists. We just wanted to clarify that if this drug is FDA approved and scheduled by the DEA, then we would use it accordingly. Any provider with a DEA registration would then be able to prescribe it to the patients. So we are here just to clarify, we don't do this for really any other drugs. This is essentially extraneous legislation. And so we just wanted to clarify that. Thank you.
Any questions?
Well, Mr. Chair, now I do have a question. I mean, to that end, why do we need to do this in advance of the FDA when they have not yet approved it and we can't have it? Are we putting the cart before the horse? I mean, I understand that we already do this is a synthesized version that we're waiting for approval on of the same drug, but synthesized drugs do not necessarily behave the same way that the organics do. So I'm curious why we have to get ahead of this.
No, I appreciate the comments of the society. I think the intent of this bill, and I'm sorry that Senator Boysko is not here to speak to it, but I think the intent was to ensure that patients get access to this as soon as they possibly can. And I understand that this is something that we don't typically, we do reschedule annually when the legislature convenes and follow typically the actions of the FDA and the DEA. If we were to follow the regulatory process, it would in effect probably delay patients getting access to this drugs by at least 2 years. As you all know, the regulatory process takes that long. And so we wouldn't necessarily, unless the board chose to do an expedited process, then we would have that 2-year delay in getting the drug into the hands of the patient.
Any other questions?
Caroline Tarrant, Executive Director of Virginia Board of Pharmacy. We do routinely schedule drugs. We already have authority in 54.1, 3443. Anytime there is a drug scheduled at the federal level, we have to wait 30 days in accordance with that code section, and then the board may schedule similarly through a regulatory activity. We do it routinely.
So, Mr.
Senator Head.
So do we need to do this?
That's probably a policy decision for you all to make. Don't feel that I could weigh in on that, but I do think the authority already exists for the board to act on this issue.
And for the question, trying to get to the segment, is there a need for an expedited approval of this, or would it in fact delay things or accelerate things if we do this, or will it make really no difference?
I don't know that it would necessarily make a difference. Because 3443 specifically says we have to wait 30 days after the posting of a Federal Register scheduling action prior to being able to act on it through rulemaking, I do question if the amendment of doing it at the next scheduled meeting, which we do typically meet as a full board on a quarterly basis, I do wonder if there might be a potential conflict. If our next scheduled meeting is 2 weeks after the feds have taken action, we will not have 30 days following based on the other code section that exists on this subject. So there could be a potential.
Senator Pekarsky.
Yeah, Mr. Chair, can Julia address that last point? And then I have another question, please.
Madam Chair. I'm sorry. Madam Chair. So as was just said, section 54.1-344.3 provides that if any substance is designated, rescheduled, or descheduled as a controlled substance under federal law, and notice of such action is given to the board may similarly control the substance under this chapter after the expiration of 30 days from the publication in the Federal Register. And then, I apologize, section 54.1-3408.05 provides that no person shall be prosecuted for acting in accordance with section 54.1-3421 or for prescribing, administering, dispensing, or possessing pursuant to a valid prescription a substance that has been approved by a prescription drug. And it provides that such immunity from prosecution shall remain in effect until the earlier of 9 months as calculated from the latter of the date of the publication in the Federal Register. And so it appears that, were those the correct code sections? Yep. I don't think that's was a question if that was in conflict. or-
Yes.
I don't
Mr.
think that's
Chair.
necessarily, because that's providing for, I apologize. Section 54.1-3408.05 is providing immunity from prosecution, and that date is for when that immunity no longer applies. Whereas, sorry, the other section of the code provides that it's 30 days from the publication in the Federal Register from which the Board of Pharmacy is permitted to act in accordance with the FDA approval and similarly reschedule, deschedule, or designate the controlled substance or drug.
Mr. Chair.
Okay.
Yes,
So,
Senator Head.
so the other question for Board of Pharmacy here is, you can, you just don't have to. If it's on the Federal Registry, you just don't have to. And what this would actually do is just say, you've got to on this particular drug just as soon as it comes in.
Right.
That would be the difference.
Yes, sir, that's how I read it. That
Okay,
we
so-
have
so that-
presently a may, this is a shall. I can tell you, we routinely do this, if that's helpful.
Thank you. And
Okay. Any further questions from Senator Head? Senator Pekarsky, any questions?
Okay.
Anybody else in the audience have any comments? I think we're okay.
Yeah.
You okay with that or no? We can move it on.
We'll have full committee.
Yeah,
All right.
sorry. Okay,
Okay, second.
okay. You want to call the roll?
Senator Boysko, Senator Pillion,
Aye.
Senator Bagby,
By proxy.
Senator Head, Senator Pekarsky.
Aye.
Ayes 4, no 0.
Okay. Bill's recommended reporting to the full committee. I would be there.
yes,
Yeah, I would be there.
Okay.
All right,
And
we're
you- back
adjourned,
to you.
right?
We are adjourned,
Thank you,
yes, yeah.
everyone. What a fun meeting.
I'd like to give Jennifer time to be